Hello and welcome back to the Oncology Brothers podcast. I'm Rahul Gosain here with my brother and co-host Rohit Gosain. And today we're thrilled to have Dr. Allison Betof Warner from Stanford to reiterate the current standard of care and also touch on recent advances in cutaneous melanoma. Be it the role of neoadjuvant immunotherapy from ASCO or the recent TILs approval, over the next few minutes, we'll try to cover it all. Allison, thank you so much for joining us.
Thank you guys for having me. Excited to be here.
Perfect. Let's get started. So covering melanoma in 15 minutes is the plan. Well, starting off with an early stage. Stage 0, where the tumor is less than 0.8 millimeters, standard of care is white excision. Even for stage 1B and stage 2A, the plan is white local excision followed by sentinel lymph node evaluation, which is recommended, where medical oncologists have very little role to play here. Now, important is stage 2B and beyond, where we get involved heavily, especially from adjuvant therapy standpoint. Can you please walk us through, Allison, what your treatment paradigm looks like here?
Yeah, absolutely. So, 2B and beyond is an ever-evolving world. I think stage 2 in general is still a really controversial space. We have approvals for single agent PD-1 in that setting. And, many patients are being treated in a particularly high risk stage 2, stage 2C, for example. But, a lot of discussion about the number needed to treat versus the number needed to harm in that patient population, given the potential long-term and permanent toxicities of immunotherapy. And so, I think there's still a lot of controversy in this space and not a lot of consensus about, should all stage 2B and above patients get adjuvant therapy? And my answer to that is no. Should some? Probably. But how do we pick that patient?
Right.
It's really, really challenging. And right now, I've seen community practitioners particularly trying to use ctDNA, commercially available tests as a predictor. And right now, I just would argue that that is not validated for melanoma. That has not been used, as a predictive tool to select therapy. That has not been validated in any clinical trial. And ctDNA for melanoma isn't that great yet. And so, is that really a good strategy? It might be eventually, but I don't think we're there yet. I would say, the vast majority of patients with stage 2 melanoma in my clinic ultimately, after a very long risk-benefit conversation, end up not going on adjuvant PD-1. And it's important to emphasize that even in the stage 3 setting, the much higher risk patient set population, late stage 3, there is still not an overall survival benefit to treatment with adjuvant PD-1. So, if we take that to a lower risk setting with stage 2, I think that's very unlikely. That doesn't mean there's not benefit to DMFS or distant metastasis-free survival or recurrence-free survival, but that needs to be weighed against the real risk of, permanent or life-changing toxicity for patients. Stage 3 is, also a really exciting space, I think, particularly in the neoadjuvant world at the moment. I'll talk about adjuvant first, just to get it out of the way. So for patients who do not get neoadjuvant therapy for whatever reason, but are found to have nodal disease at the time of surgery, adjuvant PD-1 is certainly an option versus adjuvant targeted therapy with dabrafenib and trametinib. And I think sometimes that gets forgotten. That adjuvant targeted therapy is an option for these patients. And in fact, if you look at the 5-year data and do what we teach all of our trainees not to do, which is do cross-trial comparisons, but if you actually do it, because we don't have any other choice, we don't have randomized data, the 5-year survival outcomes from adjuvant targeted therapy for stage 3 melanoma look nearly identical to the, 5-year survival outcome to adjuvant PD-1, with basically no risk of long-term toxicity in these patients. So for the patients that are BRAF mutated, I really do strongly, discuss both targeted therapy and PD-1. And, I often advocate for adjuvant targeted therapy in stage 3 patients if they do have a BRAF mutation and if it's appropriate. You know, neoadjuvant.
Allison, actually, even before we jump on neoadjuvant, I want to dial the clock back a little just before we skip or go over the adjuvant part. You brought up that stage 2B, 2C, high risk, and then we've gone to stage 3B. But I'm going to even push back to the same thing that you brought up. How much benefit are we even buying with stage 3A, which we all know that at times patients do better than stage 2C overall with this whole paradigm? And the other thing I want to reiterate while we're having this conversation, ctDNA is not the standard of care, sure in clinical trials, but it is not ready for prime time. And we've used this in colon cancer. I think GI studies are doing a good job. And clinically, that is one space I continue to heavily use it. But outside that, be it bladder cancer, be it melanoma, in the community, this is not ready for prime time.
Yeah, so I'll say two things to that. So let me start with the ctDNA piece. You know, one cancer is not the same as another cancer. So even if a ctDNA assay is good for colorectal cancer, for example, right, that does not mean it's good for melanoma. And right now, we just haven't seen strong enough data that advocate for the use of that. And you look at any guidelines, you know, ASCO, NCCN, whatever other guidelines are out there, none of them recommend the use of ctDNA yet. And so I think that's really important because I see so many referrals from the community and they walk in the door with ctDNA sent and they say, but this, but that, you know, and how do you interpret that? And I say, I don't know. I don't know the answer to that. That trial hasn't been done yet. And so I just don't think it's an appropriate use outside of clinical trials right now. Just the 3A discussion, could not agree with you more. I, in fact, think of my stage 3As the same way I had that stage 2 conversation. And we know that, you know, 3A patients, in fact, do have lower risk overall than 2C. And so, you know, the vast majority of my patients with 3A, nearly all, do not go on adjuvant therapy. And really, you know, if they are just 100%, you know, I can't sleep at night if I don't take this option, then I'm really pushing them towards targeted therapy if that's an option, because, you know, at least they know that the risk of long-term harm for those patients is really quite minimal from targeted therapy, right? They certainly have more day-to-day side effects, and we know that. But if we can manage those, right, then they tend to fade over time. And if not, you know, as soon as we stop the therapy, you know, usually within days, the side effects are gone. And so really, to me, 3A, I sort of actually lump that conversation in with my stage 2 patient.
Absolutely. This is a good segue now for neoadjuvant, because post-ESMO 2022, Dr. Sapna Patel brought it up saying it's not what you give, but also important when you give. And that was in regards to S1801 with pembrolizumab. Now we also have NADINA trial. Allison, neoadjuvant story is exciting. Your thoughts?
Yeah, couldn't agree more. I mean, neoadjuvant is the space right now, especially with, you know, anything under stage 4. I mean, you talk about melanoma and it's neoadjuvant right now. You know, I think the work Dr. Patel did with the S1801 trial, you know, was a true proof of principle of this approach, right? We can give exactly the same amount of pembrolizumab to exactly the same patient population in a randomized clinical trial. And if they get 3 cycles of pembrolizumab before surgery, they do markedly better, right? So the proof of principle that having a tumor in situ, right, probably triggers a more potent immune response, and or, right, that treating a patient earlier and trying to get at micrometastatic disease earlier is better. And so, you know, I think after SOPNA, at ESMO 2022, I mean, I think there was very little question that became the standard of care for patients with clinical stage 3 melanoma. The question has still remained, what do we use in that setting, right? So S1801 was a randomized trial of adjuvant versus neoadjuvant, but it wasn't a randomized trial of which drug to use.
Right.
And so, you know, I think there are, you know, if we look at NCCN, there are 3 potential options here, right? There's single agent PD-1. There is now NADINA, which we will come back to, or the ipilimumab plus nivolumab regimen. And then, there is a small phase 2 trial with nivolumab plus relatlimab that is, it's only 30 or so patients, did show promising results, is listed as, a potential option in NCCN for these patients. And I think for the last several years, a lot of these regimens have been used. I think Nadina, certainly as an ASCO plenary session and, with a hazard ratio of 0.32, sort of blew this out of the water. And for, fit patients who are appropriate and at a center that has the appropriate resources to treat patients with combination immunotherapy. I think it's hard to argue that at this point, flip-dose ipi-nivo should be the standard of care for patients. That is the ipi-1, nivo-3 dosing. From Nadina, we see that this is a tolerable regimen to give 2 cycles of. Very few toxicities that delayed surgery, and the patients did overwhelmingly better than giving single-agent PD-1 in the adjuvant setting. Look, do we still all wish that there was a randomized trial up front comparing these 3 regimens so we had the definitive answer? Of course we do. But in the absence of those data, I think we make the best of this that we can. I certainly think that choosing neoadjuvant pembrolizumab over doing nothing in the neoadjuvant setting is superior. But if you ask me, what are my patients getting when they come to my clinic this week, right? If they are appropriate patients that are fit, they are getting the Nadina regimen.
Allison, thank you so much for covering that. This is, in fact, remarkable for our patients, especially when you look at those curves. What we are seeing was significant EFS, and as you mentioned, the hazard ratio of 0.32, especially after just 2 cycles of combination immunotherapy based on the Nadina trial, and importantly, less financial toxicity. Now, yes, these patients, ipi-nivo had higher toxicity, 47% versus 34% in single-agent adjuvant immunotherapy, but this approach, as you stated, is in fact the new standard of care. Allison, now post-neoadjuvant, if there is residual disease present outside a clinical trial, any role for us for adjuvant BRAF MEK inhibitor for BRAF V600E patients or additional immunotherapy?
Gosh, you're asking the $1 million question here. None of us have data-driven answers to this, so all I can give you is my opinion on that. Right. What I do in my clinic, if the patients have response and our pathologists are exceptional. They are well trained on what are now the International Neoadjuvant Consortium guidelines. So, we can get some good feedback from our pathologists. Was there partial response versus no response? If there's a partial response, so first of all, I will say if there's no response and I have a BRAF mutated patient, yes, I typically am switching them to adjuvant BRAF MEK. Because I essentially say, well, it's like as if you didn't get a neoadjuvant regimen because you didn't have a response. Right. And I think you're unlikely to benefit from single agent PD-1. So why would I give that for a year? And so if you didn't respond to 2 cycles of ipi-nivo, and so yes, I'm putting them on what I expect to be effective therapy for a BRAF mutated patient. The partial responders are much harder, right? Because, they showed some benefit.
Right.
And so this comes down to a risk-benefit conversation with the patient. Were they tolerating the therapy so far, right? If patients are not having any toxicity and they had some evidence of benefit, many choose to then go on single-agent PD-1. I do complete a total of a year of therapy for those patients. And others, for the BRAF mutated patients, choose to switch. But that's very much a gray area where, man, we would love some clinical trial or at least real world data, to help guide us here.
Absolutely. Allison, thank you so much for touching on the resectable side of things, but now in metastatic stage, we have quite a few options. You brought up 3 different options, even in adjuvant settings. Similar setup here, immunotherapy single agent or combination with CTLA-4 or anti-LAG-3, or of course our BRAF MEK inhibitors. Your thought process here, and if you can also touch on the ipi dose that you brought up again, 3 mg per kg versus 1 mg per kg that we've seen with Nadina trial?
Yeah, absolutely. So, I mean, DreamSeq, I think you can't have this conversation without mentioning the DreamSeq trial, right? We have randomized data now and confirmed essentially in the Succumbent trial that says, if you have a typical melanoma patient in front of you and you are choosing, and they have a BRAF mutation, and you are choosing between, targeted therapy versus immunotherapy, at least when we compare combination ipilimumab plus nivolumab, that is superior to starting with targeted therapy. And I think that is very important for our colleagues, especially in the community, to hear. These data are out there. They are robust. There are 2 trials that show the same thing, and super important, right? Now, I will just take this one step back. I keep hearing this then applied to the adjuvant setting. But patients should get adjuvant PD-1 because of DreamSeq. That is not an appropriate interpretation of those data, right? That does not mean that immunotherapy is always superior in a different setting compared to single agent PD-1. I'm just going to put that plug in there. But when we come back to the metastatic setting, I think there's very little question, right? For your typical melanoma patient, that starting with immunotherapy is the preferred approach. Which one? And, really hard. I still think, if we look at objective response rate, if we look at long-term survival data, the gold standard right now is still ipilimumab plus nivolumab, and that is at the conventional dosing, the ipilimumab 3, nivolumab 1, that was used in, Checkmate 067. We have data that suggests that flip dose ipi-nivo or ipi-1, nivo-3 upfront looks similar. I will make the important caveat there that is not a non-inferiority trial. So we do not have non-inferiority data for that regimen. For that reason, I still, again, for the right patient, the fit patient, the young patient, with the appropriate resources around me, still prefer ipi-3, nivo-1. Nivo-Rela increasingly being used both in my clinic and thankfully now trickling down into the community. Relativity 047 showed clear superiority of nivolumab relatlimab over single agent PD-1. And, hard to argue with that now in an exploratory endpoint. So not a pre-specified endpoint, but from ASCO this year, there was an OS signal for nivolumab relatlimab over single agent PD-1. So, essentially in my mind, a typical melanoma patient should be getting some combination immunotherapy. Whether that is nivolumab ipilimumab or nivolumab relatlimab, I think depends a bit on the patient and their comorbidities. But in my clinic, at least single agent PD-1 is now reserved for elderly patients, infirm patients, lots of comorbidities, patients with autoimmune disease, because that's the only one that we have any data for. Then I typically think of BRAF MEK as later line therapy. I typically use oncorafenib and binimetinib as my preferred regimen due to overall lower rates of toxicity, but this is a little bit of trial and error. Some patients do better with one combination than the other. I typically build. The only time where I think that doesn't hold, right, are your patients in visceral crisis at the time of diagnosis, or your patients with brain metastases that have significant edema and require steroids. I do think there is a role for starting those BRAF mutated patients with targeted therapy, getting out of whatever mess you're in, shrinking the tumor, getting the patient off steroids for their brain met, then doing a planned switch to immunotherapy.
Well, there's a lot to unpack here, and thank you so much for covering that so well. With regards, before we dive into the DreamSeq and Succumbent studies, with regards to the IPI dosing, you mentioned you go with IPI-3 nivo-1, but in general, we do have the data with IPI-3, particularly for CNS involvement. When talking about CNS, what are the patients that you rely on getting the MRI brain imaging up front? Is that your standard of care or a particular patient?
Yes. I get brain MRIs on every patient 3B or above. And I do not pick a regimen until I have that information. I had a patient I saw last week. We had actually planned to start nivolumab relatlimab, but with the caveat that I needed her brain MRIs first. He actually asked if she could start before she got the brain MRI. She was asymptomatic. She had minimal low volume disease. Brain MRI came back with 20 plus brain metastases, and we started her on ipi-nivo the next day. So, we cannot overstate the value of a brain MRI. 30% of melanoma patients with advanced melanoma will have brain mets at the time of diagnosis. And those patients definitively should either be going on clinical trials or be getting ipi-3-nivo-1, which is the only regimen for which there are data.
So now, let's say we've exhausted immunotherapy and BRAF MEK inhibitors. If the disease was to progress, recently we've seen TILs getting approved here. This is based off response rate of close to 31% seen in this study. Allison, can you expand a little on this? Tumor infiltrating lymphocytes as a treatment option, side effects. How are you logistically giving this today at your center and partnering up with community centers?
Yeah, absolutely. So I'm just going to say one thing before I dive into TILs, which is you're missing one bullet point on this, which is the first bullet point there should be referral for clinical trial. Right now, in the PD-1 refractory setting, all patients should be considered for clinical trials.
Indeed.
And I think that's just an important point to make.
Yes.
That being said, TILs absolutely have changed the game, right? We finally have an option for PD-1 refractory melanoma. This is not a widely accessible treatment at the moment. This is not an easy treatment for patients. This involves a surgery, a 5-week manufacturing period, and then the administration of high-dose chemotherapy, cell infusion, and up to 6 doses of high-dose IL-2. Patients are often in the hospital for several weeks, often out of work for a period of about 3 months, and often required to, stay close to whatever center is treating them, which is often, a place that they are referred to, not necessarily close to home, for about 30 days after the cells. So this is a big treatment. I always tell my patients this is swinging a big hammer to swing at a big nail. This is a big problem and it takes a big hammer, but this is not for the faint of heart. And it's really, unfortunately, not for every patient, right? Cannot be safely given to patients with active brain metastasis, yet, cannot be given to patients with rapidly progressive disease because they cannot make it through that 5-week manufacturing period. And so it's, this is absolutely the right treatment for a subset of patients. We work very closely, so we were very fortunate at Stanford to have this up and ready on the day of the FDA approval. This was FDA approved in February of this year. And one business day later, we had our first patient in the OR doing, the first tumor resection in the world for commercial lifileucel. And we had the privilege of treating the first commercial patient in the world with this drug. We are now, firmly entrenched in the process. We're treating patients every week. But it is, it is very challenging. Logistically, it's very challenging on patients. And so, we have really worked very closely to partner with our community partners to ensure that patients can get referred quickly. This is not something that a patient can get a referral and wait 3 to 4 weeks to see, a doctor. They will progress during that time and become too sick. So we're pretty committed to seeing all TIL referrals within a week. We ask that any patient referred to us already have new scans, a brain MRI, an echo. You need to have an appropriate ejection fraction. If there's any pulmonary history at all, you need to have pulmonary function tests. All of that really should be done before referring a patient, ideally, so that, we can just get the patient into the pipeline and just,
get them
worked up and through and get them on treatment as soon as we can.
Absolutely.
Allison, cannot agree more with regards to clinical trials, and that's exactly what is taking the science ahead. Anytime you, for a community oncologist or anyone out there, if a person is in metastatic melanoma setting, not BRAF mutated, or BRAF mutated if they've exhausted immunotherapy, then clinical trials should be the way to go. And now we are glad to have this option of TILs. and what is important here as a community oncologist to partner up with tertiary and quaternary centers when exposing patients to these treatments. And we have seen a very similar thing with small cell lung cancer with BiTE therapy recently. For heme malignancies, CAR T cells are being utilized upfront, so it is very important to partner up with the right center there. Allison, thank you so much for going over all this and reiterating the standard of care for melanoma with us today. For our listeners, let us go over a quick recap. In this discussion with Dr. Allison Betof Warner from Stanford University, we have covered the current standard of care treatment for melanoma. We've had a chance to touch on the recent ASCO 2024 plenary discussion on the NADINA trial, which now should be the current standard of care for stage 3 resectable melanoma.
With Dr. Warner, we've also discussed different immunotherapy combinations, be it PD-L1 with CTLA-4 or anti-LAG-3 for the right patient with melanoma. Then, we've also covered the role of BRAF and MEK inhibitors in selected patients. Before closing, we also had a chance to touch on the recent approval of TILS therapy in melanoma. Thank you for joining us. Make sure to tune in again to stay up to date with current standard of care treatments and practice-changing discussions with us, the Oncology Brothers.